Welcome back to ER Mentorship Hub. Today we're focusing on emergency radiology and concentrating on the tibial shaft. We'll cover 4 key conditions: tibial shaft fractures, Maisonneuve injury, tibial stress fractures, and pilon fractures. Tibial shaft fractures. First, let's talk about tibial shaft fractures. Radiologically, these fractures show a break along the tibia's shaft, which can be transverse, oblique, or spiral. Radiographs are usually sufficient to demonstrate, especially in adults. Children can have subtle non-displaced or minimally displaced oblique or spiral fractures that can be more difficult to discern. Clinically, patients present with pain, swelling, and inability to bear weight. In the ER, management includes immobilization with a splint and radiographic assessment. The physical exam should include a careful neurovascular, soft tissue, and skin assessment. Leg fractures are associated with vascular injuries and compartment syndrome. Careful and repeated assessments should be performed. Treatment type of fracture. Closed, non-displaced fractures may be treated with a long leg or above-knee cast. Orthopedic referral is needed for displaced fractures, open fractures, or those with neurovascular compromise. On this X-ray, we can tibial shaft fracture. Maisonneuve injury. Next is the Maisonneuve injury. Radiologically, it consists of injury to the medial ankle, distal tibiofibular syndesmosis, injury to the and a proximal fibular fracture. An AP or mortise view of the ankle shows a medial malleolar fracture or abnormal widening of the medial joint space. If the distal tibiofibular syndesmotic space is abnormally wide, but there is no exit distal fibular fracture, and therefore a Maisonneuve injury should be suspected. An AP radiograph of the leg will demonstrate the proximal fibular shaft fracture. Clinically, patients may have ankle pain and instability, often misdiagnosed as a simple ankle sprain. They also often have proximal fibula. Other physical exam findings included tenderness over the anterior tibiofibular ligament, a positive squeeze test, and pain with external rotation. This injury requires a high-index suspicion. In the ER, stabilize the ankle and perform radiographic imaging entire length of the fibula. Refer to orthopedics for surgical management, as these injuries often require operative intervention. Looking at the X-rays, we note that there is a wide gap between the medial malleolus and the talus. This is an AP view, an obvious fracture seen. This is always a worrying sign. The ER doctor also took an X-ray of the upper part of the leg, and here we can clearly see the fracture of the proximal fibula, making it a Maisonneuve injury. Tibial stress fractures. Tibial stress fractures are a bit different. Radiologically, they may not be visible on initial X-rays. 7 to 10 days after a stress fracture develops, radiographs can detect periosteal new bone formation at the level of the fracture or a sclerotic band within the medullary bone, fracture. Acute stress fractures can be detected only with an MRI. Clinically, they present with gradual onset pain, exacerbated by activity. In the ER, management includes rest, pain relief, and sometimes immobilization. Tibial stress fractures can be posterior medial or high risk, anterior lateral. Patients present with localized pain exacerbated by impact and occasionally swelling at the site. Consider this diagnosis in patients who have recently started or increased their training regimens and present with tibial pain. Orthopedic referral is generally recommended for persistent cases or when there's a risk of complete fracture. On the first set of X-rays here, we note that they appear normal. There is nothing to suggest a fracture or any other pathology. When we look at the same leg, the stress fracture is immediately noticeable. On the last X-ray, taken after 10 days, we can now see the periosteal thickening associated with healing. Pilon fractures. Pilon fractures are severe injuries of the distal tibia. Radiologically, these involve the tibial plafond with varying degrees of articular involvement and displacement. Pilon fractures are comminuted intra-articular distal tibial fractures. They are inherently extremely unstable. AP, mortise, and lateral views of the ankle can delineate the fracture places. A CT of the ankle is often necessary for complete characterization of the fracture planes. Intra-articular fracture extension and articular surface congruity. Clinically, they are often the result of high-energy trauma and present swelling, pain, and inability to bear weight. In the ER, immediate management includes splinting, elevation, ice, and analgesia. They result from the talus being driven into the tibia. Patients will present with an obvious deformity and pain. Associated injuries include compression fractures, tibial plateau fractures, and neurovascular injuries. The soft tissues can be compromised with these injuries, and compartment syndrome can occur. Immediate orthopedic consultation is required due to the complexity of these fractures, high likelihood of surgical intervention. On the set of X-rays seen here, we see how dramatic the fracture is. These are two separate cases, but they both demonstrate how unstable the injury is. That wraps up our dive into tibial shaft emergency. Remember, accurate diagnosis and timely management can significantly impact patient outcomes. Keep an eye out for our next video where we'll explore ankle fractures and delve into the Weber classification, a must-know for anyone in emergency medicine. Thank you for joining us at ER Mentorship Hub. If this video was helpful, share and subscribe for more insightful content. Your support helps us bring more valuable medical knowledge to the forefront. Stay informed and stay prepared.